discussion of the different types of shock. In this video, I will discuss distributive shock and septic shock. Distributive shock results from excessive vasodilation and the impaired distribution of blood flow. In distributive shock, the inadequate tissue perfusion is caused by a loss of the normal responses of vascular smooth muscle to vasoconstrictive agents coupled with a direct vasodilating effect. Examples of distributive shock include septic shock, anaphylactic shock, and neurogenic shock. Clinical assessment findings of distributive shock include changes in mental status, heart rate greater than 90 beats per minute with bounding pulse rate, and increased pulse pressure in early shock. Hypotension, respiratory rate greater than 20 breaths per minute. Hyperthermia or hypothermia, decreased urine output. In early stage ABG will commonly be presented as a respiratory alkalemia secondary to hyperventilation with relative hypoxemia. In the late stage, the patient is no longer able to ventilate at the same rate and will soon develop an ABG reflecting respiratory failure. This will present as an acidosis secondary to increased CO2 and severe hypoxemia. Oxygen should be administered immediately by mask. In patients with altered mental status, respiratory distress, or severe hypotension, elective endotracheal intubation and mechanical ventilation should be considered. These avoid emergent intubation in the event of subsequent respiratory arrest. Mechanical ventilation can also aid in hemodynamic stabilization by decreasing the demands posed by the respiratory muscles on the circulation. All patients with evidence of distributive shock should have a complete blood cell count, urinalysis, electrolytes, creatinine, glucose, urine cultures, blood cultures, arterial blood gas, serum lactate, and if pneumonia is suspected, sputum gram stain and culture should be performed. All patients with distributive shock should be admitted to an intensive care unit. Vital signs and fluid intake and output should be measured and charted on an hourly basis. Daily weight should be obtained, and adequate intravascular access should be secured. Placement of pulmonary artery and arterial catheters should be considered. Different types of distributive shock require different types of treatment and mechanical ventilation strategies. An example of distributive shock is septic shock. Septic shock is the most common type of distributive shock and requires the most aggressive treatment compared to the other types of distributive shock. Distributive shock causes vasodilation of the arteries and the veins. This will cause a drop in the blood pressure, resulting in decreased blood flow to the systemic capillary bed, which will result in tissue injury and death. This will eventually lead to multi-system organ failure. I will now further discuss septic shock. Septic shock, sepsis, is defined as the presence of infection associated with systemic inflammatory response. Sepsis is described as an autodestructive process that permits the extension of the normal pathophysiologic response to infection, resulting in multiple organ dysfunction syndrome. Organ dysfunction or organ failure may be the first clinical sign of sepsis, and no organ system is immune to the consequences of the inflammatory excesses of sepsis. With sepsis, at least one of the following manifestations of inadequate organ perfusion or function is typically included. Alteration in middle state, hypoxemia where the oxygen tension is less than 72, urine output less than 30 milliliters. The following physical signs help to localize the source of infection and identify sepsis. Central nervous system infection, profound depression in middle status, signs of meningitis, head and neck infections, inflamed or swollen tympanic membranes, sinus tenderness, nasal congestion or exudate, pharyngeal erythema and exudates, inspiratory stridor, chest and pulmonary infections, dullness on percussion, bronchial breath sounds, localized rales, any evidence of consolidation, cardiac infections, any new murmur, especially in patients with a history of intravenous IV drug use, abdominal or GI infections, abdominal distension, localized tenderness, bone and soft tissue infection, focal erythema, edema tenderness, crepitus and necrotizing, Skin infections, erythema, ulceration, bullous formation. Risk factors for severe sepsis and septic shock include the following: extremes of age, less than 10 and greater than 70, primary diseases such as alcoholism, diabetes, or cardiopulmonary disease, immunosuppression, major surgery, trauma, or burns, invasive procedures such as catheters, intravascular devices, prosthetic devices, endotracheal tubes, previous antibiotic treatment, prolonged hospitalization, and other factors such as childbirth, abortion, and malnutrition. Diminished peripheral arterial vascular tone may result in dependency of blood pressures on cardiac output, causing vasodilation to result in hypotension and shock if insufficiently compensated by a rise in cardiac output. This is why often in patient assessment they will have a bounding but weak pulse. Early in septic shock, the rise in cardiac output often is limited by hypovolemia and a fall in preload because of low cardiac filling pressures. Factors responsible for myocardial depression of sepsis are myocardial depressant substances, coronary blood flow abnormalities, and pulmonary hypertension. Corticosteroids are powerful anti-inflammatory agents. They maintain vascular tone in states of shock. Early treatment with empirical antibiotics is the only other proven medical treatment in septic shock. The most important aspect of medical therapy for septic patients includes adequate oxygen delivery, crystalloid fluid administration, and broad-spectrum antibiotics. Blood transfusions may also be beneficial for patients with low hemoglobin concentrations. The patient demonstrates severe dyspnea at rest, tachypnea, and hypoxemia. Anxiety and agitation are also present. Most patients with sepsis develop respiratory distress as a manifestation of severe sepsis or septic shock. The lung injury is characterized by pathologically as diffuse alveolar damage and ranges from acute lung injury to ARDS. The patient needs intubation and mechanical ventilation for optimum respiratory support. Intubation should be considered early in the course of sepsis, even in the absence of frank hypoxia or respiratory distress. Acute lung injury leading to ARDS is a major complication of severe sepsis and septic shock. The onset of ARDS usually is within 12 to 48 hours of the inciting event. The incidence of ARDS is approximately 18% in patients with septic shock, and mortality rates approach 50%. ALI and ARDS, secondary to severe sepsis, demonstrate the manifestations of underlying sepsis and the associated multi-organ dysfunction. Pulmonary manifestations include acute respiratory distress and acute respiratory failure resulting from severe hypoxemia caused by intrapulmonary shunt. The severity of ARDS may vary from mild lung injury to severe respiratory failure. You will identify a lung injury or ARDS by examining the pulmonary artery pressure and the pulmonary capillary wedge pressure. If the pulmonary artery pressure is elevated without an increase in pulmonary capillary wedge pressure, that will help you identify that the lung is posing the problem and causing the rise in pressure. Alveolar overdistension and repetitive opening and closing of the alveoli during mechanical ventilation have been associated with increased incidence of ARDS. Low tidal volume ventilator strategies have been used to minimize this type of alveolar injury. The recommended tidal volume is 6 milliliters per kilogram of ideal body weight, with plateau pressures kept below 30 centimeters of water. Positive end expiratory pressure, PEEP, is required to prevent alveolar collapse at end expiration. Shock refers to a state of inability to maintain adequate tissue perfusion and oxygenation, ultimately causing cellular and then organ system dysfunction. Therefore, the goals of hemodynamic therapy are restoration and maintenance of adequate tissue perfusion to prevent multi-organ dysfunction. Careful clinical and invasive monitoring is required for assessment of global and regional perfusion. A mean arterial pressure lower than 60 torr or a decrease in mean arterial pressure of 40 torr from baseline defines shock at the bedside. The goals of mechanical ventilation include improvement in gas exchange, reduction of the work of breathing, avoiding oxygen toxicity, minimizing high airway pressures, avoiding further lung damage, and allowing the injured lung to heal. A lung-protected and pressure-limited ventilatory strategy has been shown to improve survival rates and lower the risk of barotrauma. Current recommendations are to use a tidal volume of 5 to 8 milliliters per kilogram of ideal body weight, to employ a longer inspiratory time, and not to exceed a transpulmonary pressure of 30 soniliters of water. Permissive hypercapnia may ensue, but is tolerated, which may occur with the use of lesser tidal volumes. In septic shock, you are also having vasodilation of the arteries and the veins. You will be able to identify this by a mean arterial pressure of less than 60 torr. The normal is 93, so as you can tell, this is a major difference. This can also be identified by a drop in 40 torr from the patient's individual baseline. This drop in blood pressure will reduce blood flow to the systemic capillary bed, thus resulting in decrease of oxygenation, resulting in tissue death and injury. This will eventually lead to multi-system organ failure. There is a lot more information to learn about different types of shock. We hope you enjoyed this brief video. Thank you.